So moving on to performing FNAC skill and fine needle aspiration biopsy should core skill in a neck lump clinic setting. So hand over to Sean, who's going to explain and demonstrate this.
Right, hi everybody. You've thankfully not got a PowerPoint presentation for mine, so it's just listening in really. So there are a few little things that you need, it's maybe worth thinking about before you start doing an FNA or a core biopsy. And I think that decision of FNA or core biopsy is quite difficult sometimes, and not uncommonly I will do both. And the one reason I'll do both is the FNA you may get back on the same day or the next day. We certainly do that at Salford. We have a same day reporting, and the core biopsy can obviously, if it's lymphoma you're thinking about, you get more definitive histology from it. So what patients do you choose and which ones do you not do? There's a lot of angst about anticoagulation, antiplatelet medications, and when you can and can't do FNAs or cores. I'm pretty relaxed with a 25 gauge orange needle for doing FNAs on anybody, whatever blood thinners they're on personally. I don't know how my colleagues feel the same in radiology. Some radiologists are brave and some won't do it if they're on anticoagulants. What do you guys think? You do, yeah. Wow, okay. Yeah, I've occasionally as well, I agree. Yeah.
It depends on thyroid FNA and their anticoagulation. The hemorrhagic sampling makes it useless. It's just, from that point of view, we would just do an FNA. We would do both in our clinic setting.
Yeah.
That's the caveat.
So I think a lot of people would, with antiplatelet medication certainly, and some of the anticoagulants do FNAs, and I think I wouldn't let that stop you doing FNAs. Core biopsies you have to think a bit more carefully, as you said, whether you go ahead with that. Other thing to share is that when you're doing the FNA in particular, you must clean all of the ultrasound jelly off the neck. The cytologists absolutely hate any ultrasound on the slide, and it can ruin their interpretation of the specimen. And we used to regularly get snotty letters or calls from one of our cytologists if there was any ultrasound on the slide. She was excellent. She doesn't work anymore with us, unfortunately, but she was excellent at doing that.
She showed this great slide, didn't she, of a smear of ultrasound jelly stained up with H&E, and it looks like colloid. So it is a problem for them.
Yeah, it's difficult. And actually, one of my colleagues, Chai Gadapali, who did for a while with us, worked in Trafford, and he had a great technique that he showed me, and I've started using ever since, is that he wipes all the jelly off. Now, the problem with the jelly, you do need it to slide up and down the neck and see what you're looking at. And what he does is he just gets one of the alcohol stick preparations or wipes, and he coats the probe with that. And that actually works just like a good temporary jelly. And this picture's, again, just as good as you've got the aquagel there for the short period of time until you get into the right position. So that's a thing I've started using for all of them now, and it stops you having the gel as a problem. Core biopsies, again, there's a variation of needles around, and different people have different types of needles. It's quite scary. It's a lot less scary coming up with a little tiny 25 gauge needle than it is one of these big beasts here. And this is the smallest one we've got, which is an 18 gauge 10 mil core biopsy. Can I open one of these?
Yeah.
What I always do is you carefully talk to the patient about it and what the process is.
And don't show them the needle.
No, I do show them the needle. And I let them listen to the needle. Because it's an explosion going off right next to their ear sometimes. And you don't want them jumping when you've got the big needle in the neck. And you should still be able to hear. So to load one of the core biopsies, you pull it back once. Sometimes you pull them twice, depends on how much of a core you need. It advances the inner needle, and then, so you could hear that throughout the room. So you can imagine if that's up here, near your parotid, right next to your neck, and you weren't expecting it. So I always say, have a listen to this. This is the sound you're going to hear. Don't worry, that's normal. That's how it works, because it can scare them. So we'll do the other thing about cores. I've had registrars say they can't get the core biopsy in, and this is when they've not come to tell me they're going to do a core biopsy, obviously. And what they haven't done is cut the skin. You've got to cut the skin. That doesn't go through the skin, that needle there. So you need to get a scalpel, nick the skin, and then get through with the needle. Otherwise, you're pushing pretty hard, and it's not much fun for them. Let's see what these are like, Susie, then. These are your homemade ones.
Let's start with them. Let me just do them.
Oh, very good. So these are the phantoms that Susan Jarrett's made some as well, haven't you, Jarrett? Very good. His cooking's very good. And these are quite a good proxy of a nodule in a patient. The pictures are quite good with the scanner machine, and there are some things inside there. I'm not sure. Was it olives you put in?
Olives and blueberries.
Olives and blueberries. Okay. All right. Fine.
We'll find something.
So when you're doing an FNA, I always get the nurses set up a tray for us, and on the tray you have the needles you need, 2 or 3 needles with, and these 25 gauge needles come in different lengths. I don't know if you can see that one. If you can see it in front of the screen, that's a slightly longer length. I think that's about 1.5 inches in old money, and the other length, the standard length, is about 1 inch. And you gauge when you look at the patients the depth of how far the nodule is, which of these is going to be better, because sometimes you get inadequate FNAs because your needle isn't long enough, and that can be a problem. So you've got the needles, you've checked the needles are right, you've got everything you need on the tray. It depends on your cytology department's preferences of what samples they want. So some places want air-dried and fixed slides. Some want just air-dried and cytospin slides. Some departments like ours will send a technician up, and so all you do is you take your sample and you say, there you go, and then they sort everything out, you do nothing else. And that's quite a good way of doing it. Although I watch some of the new people doing it, and anyways, but the key thing if you're doing it yourself is once you've got your sample, and we'll show you how to do the sample in a second, you shouldn't have a lot of tissue or fluid in the actual, you should have none in the syringe, ideally, unless it's a cyst, and you should possibly see some in the bevel of the needle at the most. Any more than that, you've got too much usually, okay? When you're ready to plate the slide, I always, before I put the needle in, put some air into the syringe to start with, so that you've got something that when you're aspirating onto the slide, you can aspirate it out. What you don't want to do is do the sample, take it out, and then just get some air in and aspirate it. You've just sucked it all into the bevel of into the actual syringe, and you might not get it out, a good sample out. So you've either done the sample yourself, spreading it. We're not got a sample on spreading the actual slides because we haven't got the cytologist here. It is important. The sample you get corresponds to the quality of your cytology reporting and how you prepare the sample. So if you've got to do it yourself, it's worth learning either from the cytologists or the technicians of how you actually do spread a slide. The key way to do it really is if you've just got a very small sample in there, not too much, then I would have the slides set up. You remember the slides have got a frosted area where you write the patient's details on. That should be done before you spread a slide. So all the details should be put onto the slides in preparation. You then get the needle. The needles have got bevels. So make sure the bevel is pointing down. You don't want it pointing up or it might squirt away from the slides. These are all things we've all done. Get the bevel in the right direction. If you look at a slide that's sitting like that, you've got the frosted area at the bottom. You want to put the dot just beyond the frosted area of sample. So you put a dot on there. You don't need huge volumes. You don't want to squirt all of it onto one slide. So you just need a dot of fluid or fluid cells in on there. You then get your blank slide. You let the other slide fall onto the dot and slide gently away. And then what you ideally want when you've done that is you want to look up to the light, and it should look like a thumbprint. If you've got a thumbprint or a smear with a thumbprint, that's the thing that they're going to like for. And they like the differentiation of heavy material at the start of where there is, and it thins out as it goes further out. And they can look at the cytologists can look at the gradation of cells there. If you get huge volumes out, if you've got, well, not huge, if you've got a cyst, you'll get a lot. But if you get a little bit more with blood in, I do sometimes do initial few drops into the cytospin prep bottle. So do the excess into there, and then I do the drops onto the slides after that. And that seems to work quite well. The actual physical technique of how you do it varies amongst clinicians and radiologists. So you can do it 2 ways with an FNA. You can either do it in line with the probe. So as you're coming in, it's in the same line as the orientation of the probe. And the benefit of that I'll show you at the minute when we're on the screen. But you will see the needle in its full length going into the actual specimen. We'll put that on here in a second. The downside is that sometimes, especially if you've got a long probe, this is quite a nice short probe here. Some of them are about 50% longer than that you use. And the nodule can, if it's deep, be a fair distance away. So you need to go in a little bit further away, and you need the long needle is quite often very useful for this scenario. But benefits are you see the whole of the needle and you can see where you're putting it. Other people, including me, do at 90 degrees to the probe. So you find the sample, and then the needle comes in at an angle so that it's going to hit the probe here, and then you can see the end of the needle in the sample specimen. Downsides of that is you may not see it until it actually comes into your probe's channel area, so you might miss that. But I find it on smaller nodules actually easier doing it that way, to be honest. So it's coming on the screen, is it here? So let's have a little look. So here we are. We've got a good. There's quite a deep one there. Might need to change the depth on the thing here, don't we? So we've got this right around. Yeah. Yep. Well, there's certainly something in the middle there. There's hypoechoic, isn't it? That's better. Yeah, that's good. So we've got the lesion nice and central in our probe there. So if you're going to come in, I'm going to do it my way first, which is at a right angle. So the key is to look where you are. I've got it in the center of my probe here. As we go in, I'm advancing, but you can't see the needle yet. But there it's coming in here. See it there? You can see your angle now. I'm a little bit off center there. I've drifted. So I'm just going to adjust myself. There it is there. See it sliding in and out of the olive? They are pitted olives because I'm not hitting a stone there. All right. And the other thing to do is you don't need to put a huge amount of suction on. So what I tend to do is I do a rotating movement. All right. You can feel it coring olive up into it. It's nice. And that will, by capillary action, that will pull enough sample, usually, into the bevel of the syringe, and you can stop. If you see nothing, then I do sometimes add a little bit of suction just to see if I've got something. Or you can take it out, spread it, and see if you've got something, which is probably the more scientifically correct way to do it. Okay? So then you take it out, and you do remember you've got a bit of air in there. You can do your first samples. If you need to do more, take the needle off, re-aerate the syringe, and plunge it through again. So that works for me. A lot of people like to do it in line, so it's the same process. Here we are, we're just now in line with the probe. See the needle coming in there? Just check, if you're not seeing it, you've drifted offline. And you can wiggle it backwards and forwards. There it is, that's better. Again, I can feel I'm into that olive there. But I'm at the limits of this. The bevel is now touching the phantom. So it's struggling to get down that far. It's quite a deep olive, that one. You can just see it. You can just see the needle, end of the needle, going in and out of the olive, and I'm rotating around, taking a sample. And the rotation is a good maneuver. And then got any out. You hear that little psst, that was the sample coming out. So you know you've got a good sample there. So that's the techniques. Core biopsies. I've got to be honest, sometimes what I do with core biopsies, because I find it much harder to do a core biopsy with ultrasound guidance. So it is the correct way to do it. And we'll show you what we do. And I think probably if you can do it in line, it's the best way to do it. It's a big needle, a core biopsy needle, comparatively to what you're doing. So where's our olive again? There he is. So the thing about core is you've got to make sure it's fully, you can't have it halfway out like that, or else it'll catch. So the needle has to be, activated and then retracted. You've cut the skin already, and then it dribbles, the skin constantly dribbles, and it's a bit of a pain in the backside. But then you've obviously put the local anaesthetic in. I tend not to put local anaesthetic in for fine needles. I don't know if everybody else is the same. You stop now, yeah. It tends to be exactly there. That was my feeling as well. So you can see the core biopsy needle coming down towards us. You can just see it there. And it's going into that area there. Now, when you're pushing, the one thing you've got to be aware of is when you're doing the core, you're going to push it further in. So you've got that extra centimetre or so of core. So as we advance now the core biopsy, you can see it going in. You can just make sure you're in the centre of that lesion. And then you activate it. It pulls that core into it. You take it out, and we should have a core of olive. Which we do perfectly there, yes. One of the most pain in the backside bits of it is getting that core off the needle, off and off. And so don't throw your scalpel away once you've nicked the skin. The back of the scalpel is quite a useful way of dragging the core off. The other thing you can do is when you've got your pot of formalin, because the core biopsy goes in formalin, remember, it's a histology specimen, you can wiggle the needle in the formalin, shake it dry. A bit of formalin in the neck's never killed anybody as far as I'm aware, because you can use the same needle again for more specimens. And I tend to take usually between 3 and 5 cores, depending on what the sample looks like, for patients. Main fears are hematomas, obviously. Hematomas from FNAs, they do happen, and not super commonly, but we do see them occasionally. Infections can also occur, so even if we do clean the skin, which we do, but you get some patients can get infections. Hematomas are slightly higher risk, obviously, with a bigger needle, core biopsy needle. I've had one hematoma from a core biopsy needle. Specimen came back as large muscular vessel wall, which was obviously it was a facial artery I managed to biopsy instead of the lymph node, but never mind. It stopped by pressing on it for a while. And that's it really. Patients just need a elastoplast on it afterwards. Press on it for a few minutes. If you've got a nurse, that's what is perfect for us. You guys have got radiographers, but they may not be available with you to help, but having somebody to press on that for a while. After a core biopsy, I usually keep a patient with us in the clinic for about 15 minutes, 10-15 minutes, make sure it's okay. The FNAs just disappear when they're not going, as long as they don't faint. What do you do for the faint? Just lie them down. If they're on a chair, they can go on the floor. Any questions? Yes.
I don't know if you FNA or biopsy parotid lesions.
I do.
What's the risk with hitting facial nerve and things like that? Is that an issue?
Theoretically, I've never seen it. I don't think you have, Jared. On an FNA, it's highly, highly unlikely to be a problem. I mean, you could probably nip through the main trunk with a needle and it probably wouldn't cause major problems. A core biopsy, theoretically, you could catch it, but it does seem to just bounce out of the way. We don't do huge numbers of cores on parotids. We do occasional cores, but most of it you can get off an FNA. But I've never seen a nerve injury from it, no. I did once have a patient who I did put some local anaesthetic in because I was doing a core biopsy, and it was in the deep cervical chain, and core biopsy went absolutely fine, but I kept him outside for 10 minutes and he came back and said, "I've gone very hoarse." And in half an hour it got better when his local anaesthetic had worn off. They'd got the vagus nerve for a short period of time, the local anaesthetic. But yeah, and these are theoretical risks, and you have to mention them to the patient, but from nerve injuries from the actual needles is super rare.
What kind of consent do you give?
So I do a verbal consent, and I document that in the clinic letter. So I'll mention after verbal consent, the patient agreed to such and such. We've got a new system called Hive, and if I wanted to do it properly on Hive, I could see one patient in a clinic probably by the time you click. The number of clicks you have to do a consent form in Hive is phenomenal. But it is a good point. Theoretically, we probably should be doing a full theatre safe surgery checklist for all of these patients.
That was my next question.
Yeah, but it should. We don't do a WHO checklist, but if we're going to do it by the letter, that's what we should do. Correct. Because we are taking a sample from a patient, and it is the potential, and we've all certainly, and that's why it's good having a person with you, because if you've written right thyroid and you've got a nurse who knows you're not always the brightest on which side you're on and can say, that was a left, wasn't it? And you go, yes, left thyroid. But it isn't. But you're probably right. We probably should really do.
No, I don't think we should. I'm anti.
Theoretically, but we don't do it. We don't do it because we haven't
I
got.
don't do the
We just certainly haven't got time to
I
do
was
it.
just wondering if you did.
No, never have.